Welcome to the Buddhi Insight. Today we are discussing emotional dysregulation, which is a common problem across neurological and mental health conditions. And I have with me both Vivek Mishra, who's a neuroscientist and our clinical lead for neuroscience, and Dr. Mukul Shakti, who's an accomplished psychiatrist and psychotherapist who works with people who struggle with these issues. And to set context, I should probably say that we are very interested in this particular topic of emotional dysregulation in Buddhi Clinic. So, welcome to both of you.
Thank you.
So, just for the listener to qualify this, I think what we are talking about is people having out of proportion, amplified responses to situations and circumstances. And those can be responses of anger, those can be responses of sadness, crying, dysphoria, and those can even be responses of euphoria. And the qualifying feature is that they are not what the situation demands. They are far out of proportion to the situation. And we, of course, encounter them in a range of mental health and neurological conditions. We see it with traumatic brain injury, we see it after stroke, we see it with dementia, we see it with depression, we see it with addictive behaviors, we see it in people with bipolar disorder, we see it with schizophrenia. It's astonishing the number of conditions with which people present with emotional dysregulation. So different diagnoses seem to share this common rubric. And I'd like to start by asking you, Vivek, what, from a neuroscientific perspective, what drives this? How does this happen?
When we talk about the emotional dysregulation, it is more of a top-down control failure. It is our prefrontal cortex regulates our amygdala reactivity. Now, as you are saying that we are seeing it's more of a trans diagnostics, be it ADHD, depression, anxiety, panic disorder. It is the failure to regulate our limbic system coming from the inputs coming from the prefrontal cortex. And that's what lead. So it is a common braking mechanism. And when it's not there, we are looking for the emotional dysregulation. So in short, it is the networks which are common in our behavior, which supposed to work or regulate are not optimally regulating that particular network and causing the emotional dysregulation.
And probably it's good to put context to this with remembering Alexander Luria, the famous Russian neuropsychologist, who described how the limbic outflow can sometimes overwhelm the frontal cortex and result in behavioral and emotional outbreaks, and vice versa. When there is a frontal cortex problem, how even normal limbic outflow is not adequately managed or controlled, and those are very well brought out in what you say. um, Dr. Mugil, do tell us from a clinical perspective, an everyday clinical practice, how does this play out? What do you see?
So, from a clinical perspective, when the patients are brought to us by the caretakers, so usually the complaint that they come with is that so he is becoming more angry than he should in that situation. So an emotion that occurs disproportionate to the trigger or the event or the situation, and emotions that last longer than they actually should, and emotions that feel much more intense than what the person is able to handle. So these three are the major complaints that the patients, the caretakers come with when they bring the patients to our clinic. So it's like often we have this example that when I get them to understand, I give them the example of the big bells that we see in Buddhist temples. We ring it and the reverberation stays for quite some time. So emotional dysregulation can be thought of from that angle. Also from the angle of a vehicle, a car with an engine that's too powerful for the driver to handle. So these are the themes of emotional dysregulation with which the patients come. So it is associated with poor frustration tolerance, impulsivity, and other features and so on.
Interestingly, you bring out two things. One is that the person may not themselves be aware that they are dysregulated.
Yes, yes, sir.
And the other very important point that you bring out is it's not just the intensity, it is the duration.
Yes,
How
yes.
long does this problem continue that makes it difficult for the caretaker to handle? So I think those are very, very interesting observations. Now, obviously, when you're going through all this, you can't think very clearly, right?
Yes, sir.
And I want to understand a little more from you, Vivek. How does the emotional brain overwhelm the logical or thinking brain?
So, when the amygdala and the salience networks get into the high alert mode, so the brain deprioritizes our prefrontal cortex, and we find that the amygdala and the salience network is not even competing with the prefrontal cortex. It is just working in a parallel context. And when something like that is happening, for example, we can't argue with anyone having a panic disorder. Why? Because we always talk about think, plan, focus, reflection, and all these are prefrontal cortex functions. But on the paradox is when the amygdala and salience network is firing, we are employing the emotional brain rather than the thinking brain. And that's where the tug of war which started happening, that should the brain should be thinking or it's moved away from that deliberately within the system. And those networks are the, like if we can just say, right now, do I have to think and respond to a threat, or should I just escape and then later come to a thinking that was it even a threat? Just like having a snake. We see a snake and we run away. We don't think, is it poisonous or is it not poisonous? It is first instances, just run away from it. So I think that is what the circuit level science tells us.
You mentioned both amygdala and salience network. Can you tell for the person who doesn't know what these are? What are they?
So amygdala, deriving its name from the Greek and the Latin background called the almond shape. So it is exactly a almond shaped deep-seated group of networks, or what we call the nuclei, which have the projections or the networks surrounding the other networks like mammillary bodies, which controls and commands the information processing or emotional regulation. So as we are talking about the emotional dysregulation, the amygdala and the limbic system again make this thing happening. So goes for the salience network. So not a single thing can control our emotions. It have projections from different. For example, if we say we are getting the sense of a smell, say a gas leak is happening. So the projections coming from our hippocampus, understanding, oh, this can be the, like, the LPG gas smell, which is a threat. So everything gets into those big networks and it drives the information to the amygdala limbic system to process it. And that process sometime outrun our thinking brain. So I will just put it at that.
So we have these systems in our brain that assess every stimulus that is in front of us and do a threat-based assessment. Does this require a response? What kind of a response? And the amygdala and the surrounding limbic system are very key elements of that circuit. Mukil, how does this affect psychotherapy? The fact that someone is so emotionally dysregulated. I mean, you spend lots of time talking to people.
Yes.
How does this affect that?
So, sir, the brain works on the principle of energy efficiency and automation. Right? So, like Mr. Vivek was saying, so the brain that's very preoccupied with picking up threats and saving the person from the pain or the consequences of the threat. New learning does not happen. The brain is not open to receive information. Rather, it navigates situations and events and scenarios by ensuring that okay, I have experienced pain in the past, and now I have to do everything in my utmost ability to be able to avoid that experience. And when that happens, we are stuck in old patterns, preconceived patterns, right? And when we are stuck in those patterns, therapy does not get across to the patient. So when we are trying to so the brain is not convinced yet that I have to change my stance. The brain is not convinced that I have to change my functioning from here, from having to protect myself, to a new learning, a new pattern of behavior where I can actually think beyond what happened in the past and move ahead towards new learning and a new sense of identity and self. So that, yes, so that is how it interferes. So when there is emotional dysregulation, we are so preoccupied with protecting ourselves that we don't see beyond what has happened in the past.
So in a sense, that's very interesting. What you're saying is that brain is a prediction machine. We all know that.
Yes.
We've got some preconceived predictions happening. Yes. And that's what is leading to the emotional dysregulation.
Yes, absolutely, sir.
And I am not able to let go of that in order to change my patterns of thinking.
Yes.
Which is the first step, therefore, is my being able to step away from that, see it for what it is, and then be willing to change my patterns of thinking.
Yes, sir.
That brings us very neatly to this discussion on the therapy window, because we all know that in therapy, the window has to open at some point in time for us to start making progress. And if I can ask the scientific question first, how do drugs, how do neuromodulation techniques that you use very widely, how do they open a therapy window?
So just to look at that the medication or the neuromodulation, they don't do psychological work. For example, SSRI or TMS, they don't change the brain to do or I will say, so the medication and neuromodulation don't do the psychological work. A session like TMS or a medication like SSRI, they make the brain available to do the psychological work. And when we talk about just the neuromodulation, while stimulating our prefrontal cortex, which is the front side of our brain, it enhances the prefrontal cortex limbic brain connectivity. Now, when the connectivity is enhanced, it is just like turning down the emotional brain and bringing the bandwidth to the thinking brain. So it doesn't make insights to the patient, more like it's making the patient incitable, and then the psychological work starts. So it's just like bringing the balance back, as we discussed before, that the limbic brain stop competing with the prefrontal cortex and it's overpower it. Now we are making our frontal lobe to again gain its prominence, and the person starts thinking and react appropriately.
Right. That's very, very interesting. And when you're working with somebody like this, they're going through neuromodulation, they're going through TMS or deep TMS, and then they are also, maybe taking medication. What do you experience as the therapy window opening, and how does that make a difference?
So with medications and neuromodulation, what we do is medications silence the noise in the mind, and the neuromodulation gives the sufficient ability for the frontal lobe to put the brakes. So now the car has been put on brakes and the noise is reduced. Now you teach the person that okay, there's no, I mean, you don't have reasons to be emotionally dysregulated. Now the state has changed. You're changing the state. Now you're coming down, and when that happens, we can see that the person becomes more inquisitive. Now he started asking questions. Now he started pondering, okay, why has that happened? Why did I react to that way? And they are more ready to work. They become more introspective, to use the right word. They become more introspective, and so in between sessions we tend to give them activities to do, and they are more ready to do that, and they even come back with the results, and that's how we know that they are becoming responsive to therapy.
So you clinically, as you work with a person, you are beginning to see a change.
Yes, sir.
In their ability to introspect and their ability to modify or modulate
Yes, 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 sir.
things that earlier was harder for them to do.
Yes, sir.
I like your analogy also of removing the noise. So, in a way, both of you, from what you're telling me, it's a little bit like a gardener tending a garden. You have to first prepare the soil
Yes, yes.
before you put in the seeds and start watering them in order to have the plants grow.
Absolutely, sir.
And to some extent, preparing the soil is what the neuromodulation and the pharmacotherapy is doing. Because so many people are so afraid of taking medication. They think that they'll have to take it for life, or they think that it's going to be very hard to come out of. And one of the things I'm always telling people, no, it's part of the process of getting you to progress. It's not the process. The process is much more than that. So there is a prescription of medication, there is neuromodulation, which is another key part of the process. And then, of course, there is psychotherapy, which is an important part of the process. And mental health, therefore, has to be in this way holistic, that we do all these things simultaneously in order to help the person. And that therapy window opening is a very, very nice example that you gave there. Now, we often talk about insight, awareness of my own condition. And that's such an important thing in mental health, that very often people come to us lacking insight, not understanding that they have a problem. So you have relatives, family telling you that, oh, this person is having a serious problem. And the person is telling you, no, I'm perfectly all right. There is nothing wrong with. In fact, even yesterday we had someone like that, interestingly, with post-stroke depression, who was in denial and didn't see the point in getting treated. Even though he was paralyzed on one side of his body, even though he could not use his upper limb properly, even though his swallowing and his voice were affected by the stroke. Despite all that, he did not have insight into what it had done to him. So we do see this in so many different ways, this lack of insight. How does insight become suddenly possible when you are working with technology? How does technology bring that insight out?
Sure. So, sir, if we build upon that, the insight often isn't about any new information. It is about how our old networks, essentially the default mode network and the prefrontal cortex and the circuitry, is processing the information. Now, due to the insult or the trauma, it can be the stroke or any network or circuit based. Essentially, the neuromodulation do think that everything is circuit based, and now we are seeing the circuits are not working properly. So, the information what we could have processed, it's not getting processed in a way what is more acceptable. It can be the insights about the self condition. The networks become rigid, and the point we started to stimulate, for example, we say the precuneus stimulation, we are talking about the prefrontal or the supplementary motor area stimulation, which are very close to the default mode network. We are rejigging them and making it make more sense, and suddenly we find that the information starts coming back, or we are making sense of the information. So I will put it, recently I was just reading one of the posts on the JAMA psychiatry. So we have data, meaningful data become the information. The information, when we connect a dot, become insight, and how to navigate from that insight become the wisdom. So we are looking from the data from the brain to get that wisdom, and we have to just connect the dots, and the dots is the default mode network what we are looking to stimulate and make patient more aware. And this goes exactly the same in a patient with stroke and the hemispheric neglect. He don't know whether the hand is not moving, and exactly what, when we stimulate using the TMS, using the 1020 system and the brain atlas, we are stimulating the point affected side with a high frequency, unaffected side with a low frequency, to bring that balance back. And then they start looking at the hand, or once they are indulging in the fine motor activities with the robotics like Gallant or what we are looking recently, And exactly it does. I'm not moving it, but I'm using mirror neuron therapies based on that. So I think the networks, default mode network and the prefrontal cortex circuitry is the key there.
And that's exactly what you're stimulating when you use something like DMS. So that's very, very interesting. But to you, as person working with the human and talking to them, how does this moment of insight appear? Share with us, perhaps even a story, how insight comes out suddenly when a person is going through therapy while also going through something like neuromodulation.
So, with regards to insight, I'll put it in two ways, sir. One is the intellectual part of the insight, and the other is the emotional part of it. So, with regards to the, like connecting the previous question. So, when the intellectual insight happens, it is parallel with the opening of the therapy window. So now the person becomes more introspective. So okay, why did this happen? What could I have done there? Like what is making me do this? And it culminates to a point where they experience emotional insight. I always tell my patients, thoughts travel linearly, emotions travel in waves. Thoughts travel faster than emotions. So even in spite of you knowing something, for you to be able to realize it, it takes some amount of work, some amount of being okay with your own emotions, right? So that emotional insight is a eureka moment. So that's when the past and the future collapse into the present moment, and learning and realization happens, and the journey culminates into the present. So now the person is not reflecting on the past and neither projecting onto the future, but now is more aware and is more in touch with his own emotions. What is causing my problem? Where is it arising from? So I have an emotion, and probably let me not invalidate it, but rather accept it and learn to channelize it in a better way. So there is this interesting patient, a middle-aged man who's a working professional. It's one among the, I will say, a top working professional. So he was diagnosed with OCD when he was 13 years old, and he has been having this ailment for about, let's say, 3-4 decades. He has been on medications and on therapy in and out, with waxing and waning of the symptoms. But though many therapeutic techniques that were used to address his issues, many were used in the past, it did not pay as much result as he would have liked it to. So it came to a point where where I connected with him based on his thought framework, and told him, look, you, instead of pathologizing this thought and going into the cycles of obsessions and compulsions, why not you look at it through a different framework, possibly a spiritual framework. Add a different level of meaning to it so that you can be more okay with the drive, and choose to not act upon it, and choose to not let it come to the forefront than your other moral, like let your moral compass lead, but accept the behavior. So for him, that was a eureka moment where he went into silence for about a minute or so, for nearly a minute or so, and it was quite a deep and intense moment where he said, okay, now everything makes sense. Now I am looking at myself as a completely different person. So that's how it felt like. That's how it feels like to have a insightful moment like that.
So I like that analogy of connecting the dots, which Vivek put out. I also like your distinction between intellectual and emotional insight. So it's not enough to become aware. It is important that you emotionally become connected with that awareness. And you're saying being in the moment has a very strong, what shall I say, spiritual bent of mind to it, because obviously that's what many traditions that talk about well-being ask you to be in the moment, stay in the moment. So I think that comes together very nicely. So one of the interesting things that people say is what we see as mental health symptoms are the brain's attempt to survive. And when you look at it from that perspective, you were talking, Dr. Mogil, about a young girl for whom imagination became her refuge. Would you like to tell us that story?
So this story about a young girl who I had seen in my clinical experience. So she was brought by her parents mainly for screen addiction and let's say emotional dysregulation, where she was snapping at her parents for everything, for being asked to study, for being asked to do her routine chores. She was snapping back at them for that. So refusal to go to school. Right. So, and one among the symptoms was that she found it very hard to be able to relate with her peers, and with by exploring. No? So the ability to not be able to relate with her peers was also added on to by the distress that she felt they had some ulterior motives towards her friends at school. So, I mean, with evaluation, we found that there was, apart from the depression that was being masked by the phone usage and the comorbid anxiety, there was also presence of features of ADHD and autism spectrum on the background of this. So, naturally, with autism, we know that the brain activates in slightly different patterns compared to their peers. So, her interesting way of adapting to this was that she used to try lucid dreaming when she went to sleep. So, and in her lucid dreaming experience, she would create, it's an abstract concept. She would create discrete packets of data of about the things that she couldn't connect with or relate with in real life, be it people, be it systems and institutions, and she used to imagine herself assimilating it onto her, like making it one with herself. So this experience could be thought of as something related to quasi psychosis, leading to leading to full blown psychosis. But in her case, in her case, I rather consider this as an adaptive coping strategy of her inert need to actually feel belonged. I mean, it is a fundamental human being's need. No, it's a fundamental need to feel belong to the place where you are, belong to the people who you are with. So as that was not happening because of her challenges due to her underlying conditions, she used this as a coping strategy to be able to adapt, to feel, to calm her own emotions.
So an imaginative world can sometimes be an adaptive coping strategy, uh, in generally in mental health, but also especially for people who are neurodivergent. Because it also tells you what the latent wishes and desires are. From a neuroscientific perspective, what is happening when a person is trying this kind of adaptive coping mechanism?
So, when we look at how our brain is processing, and as Dr. Mughal said, that it is a coping mechanism, which means the brain is using whatever available resources are there at its disposal to cope up with the unbearable situations. Just the example of dissociation or even the obsession, it's like it's part to protect the person. So if the person's threat is just based on that there should be money in this drawer. Now, my whole security environment is if there is a money in the drawer, I am safe. I keep on checking whether it's there or not. So it's just making sense of what is available and what I am using it. And if we just look at the brain, how we can connect just like a climate and the weather. So the mood is just like a climate. It is like, if it's a hot or a humid climate, it is a climate. Whereas the emotion is like a weather and it keeps on changing based on the need. And I think that's where the adaptive behavior systems in the brain comes into picture, that sometimes the people are not all the times they are having the symptoms. Even if when we look for the Y box for the OCD, we are just saying that are you spending 6 hours to 8 hours at the maximum in that task? It's not 24 hours. So I think using the brain's best available resources, making it use them, is what we are looking, and removing any of that is also not like, it is just like removing the safety mechanism and pushing them over the cliff. I think that's where the psychotherapeutic approaches really help.
So one challenge that we see is that, so these are adapted as scope, safety mechanisms.
Yeah.
So it is not very you don't see that they come out with it very easily when in therapy. So you need to do a lot of connection with them, like you need to work on the connect with them, and a lot of talking has to happen before they open up about these things. So
But I think the other very interesting thing which people should realize is, however distressed, however dysfunctional a person has become because of their mental health, there is plenty of available brain resource still there in the person. And these adaptations are examples of that. That I may not be very functional when you look at me, but I have internal mechanisms that help me function, which I am continuing to use. It's just that I'm not doing it in a way that you appreciate, or I'm not doing it in a way that you're able to see. And I think you talked about this person presenting with a digital addiction. And we see this in a lot of young people today, that you cannot get them away from their smartphone or tablet or gaming tools. But for many of them, it may be a bad way of coping with a genuine problem that is within. And we don't understand it's a symptom of that we are seeing. Very often we don't get that it's that symptom that we are seeing as emotional dysregulation, or behavioral issues, or indeed low mood, or indeed, as Vivek talked about, obsessions. uh, we are seeing, we're seeing that for that reason. And I think we really need people to become aware of that. So two lessons to take away, I think. One, that there are good and bad coping mechanisms, and very often it's important we are aware of that, but also that there is a neuroscience behind the coping mechanism, and the brain is a predictive organ with plenty of resource, even in someone who is dysfunctional. So that brought us very nicely to OCD, and we talked about obsessive compulsive disorder as is one of the situations where both adaptive coping and emotional dysregulation happens. But at the heart of it are irrational thoughts. And do describe to us, Vivek, what is the neuroscience behind having an irrational thought?
So, when we talk about the irrational thoughts or the obsessions, they are very specifically mapped on a very significant pathway called the corticostriatal thalamic cortical. So it's like we say it like a CSTC. So this pathway, the loop gone into a hyperactive mode. Everyone checks. Like, it is a very common phenomenon that when we lock, we have to just check it. But what's really happening over there is the thalamus, which is the central pathways, or like is just like a transformer in our brain that gives a signal that okay, we have checked, and pass on to the prefrontal cortex. Now what really happens is the logic says yes, it is done. But what if the thalamus overfires again, and that we got into this loop? So even though that there is a evidence that we should not have the irrational thought, this CSTC loop overfiring make us just do the things again and again. And the another network, or like the system, the insula, adds the contention of something is not right and I have to do it again and again. And based on this, the newer modalities like what we just got, the deep TMS, the BrainsWeight deep TMS H7 coil, which stimulates the insula. So when we are able to target that particular networks which are going into a overactive or a hyperactive mode, we are trying to modulate those. So that's the underlying mechanism of this CSTC, which is quite of a mouthful, but it is when we say the cortical striatal thalamic cortical loops, and that makes the basis of our understanding of the OCD or obsessions, or it can be the irrational thoughts or fear.
So there is a specific brain pathway that's affected in OCD. And this particular brain pathway is what you're stimulating with the deep TMS.
Yeah.
And it is the advantage of the deep TMS is that it is actually specifically able to target this pathway.
Yeah.
And its penetration into the brain is greater than most other neuromodulation modalities.
Yes.
Am I right?
So, if we compare anything non-invasive, the deep TMS coils can not only penetrate deeper, but it have a ability to stimulate the whole network at once. And that is the reason that we are not looking for a 40-minute or a long protocols. Usually the deep TMS is just 20 minutes. Actually, the OCD pathway coils are just 17 minutes, which can able to deliver that strong impetus, stimulating the whole networks. And the patient is just like a live example. The patient who started last week. So when I asked him on those Friday sessions, and he said that he already started seeing a change, and he is suffering with OCD for roughly 12 years now. And when he is saying that there is a change, definitely we are working on much deeper rather than the superficial context when it comes to the brain stimulation. So.
Excellent. And how do you see the rigidity soften when it comes to the therapy window?
So when the rigidity softens, the emotional defenses fall down. The emotional defenses lower, and no. So if we dig deep down and see, mostly the people with OCD, it is based on thought schemas of guilt and shame, mostly. Right? So and their fear is that they may commit something grievous based on that shame, based on that guilt. I shouldn't do that. So rather, and human beings are inherently ritualistic in nature. Right? So we like doing a set sequence of activities to be able to have some kind of an emotional accomplishment. And OCD is that ritualistic nature gone wrong, gone bad. Like we were speaking about maladaptive behaviors, maladaptive coping mechanisms. So when that rigidity with that ritual falls down, now they don't experience the same level of emotional intensity of fear, the emotion of fear that they did with regards to those schemas in the past. And now they are able to sit with their own inner fears, their own inner fears that I might commit this, I might do that, I might bring this upon me. Now they are able to sit more balanced with those thoughts, and that is again one therapeutic window which helps us to connect and work with the patient.
Excellent. Turning the page. Let's talk a little bit about spirituality. We alluded to it a little earlier. There is, in general, a conflict between neuroscience and spirituality. Yet we have a fair amount of neuroscientific data on spiritual experience. For example, we know that the limbic system, you are alluding, the amygdala, the hippocampus, these areas, especially on the right side, have been, talked about as having a role to play in spiritual experiences. So tell us, is there really a conflict between neuroscience and spirituality, or are we imagining this conflict?
So, I don't think that there is a conflict. The neuroscience provides the mechanism and the spirituality provides the meaning to it. So, if we are looking or associating with each other, so the neuroscience with spirituality and the vice versa, it doesn't, strip off its importance. It is just shows that how much important it is to make the meaning of what kind of sense we are making it. And usually people do also get confused between the religiosity and the spirituality. And one of the labs which I always, usually follow is Professor Anil Seth, who is the, I think, director of the Department of Consciousness Studies. And that's where, there is a connect which comes that if we are spiritual or we have a moral compass, that what if there is a meaning to whatever we do and we take a right call. And there are lots of fMRI, as you are saying, so that we are looking for the data coming from the fMRI studies. We are talking about the structural studies, which shows that how a person is behaving. So I don't think there is a conflict. It is just how we are making sense of it. And Usually we should not go and bash the either of the modalities if they are, or the stream of thoughts if they are interconnected to each other. So
When you spend hours talking to people, how do these spiritual conversations, spiritual insights, how do they emerge in therapy, and how do we deal with them?
So, sir, usually the notion is that spirituality is a coping mechanism. That's how it is. There is a tendency to think about spirituality in that way, but I would say that it adds meaning. It adds more layers to life. So you have the like Mr. Vivek was saying. So there is the experience, but where's the evidence? There is the evidence, and what experiencing is it leading to? Right? So as therapy proceeds, and we dig deeper into their the deeper thought schemas and deeper thought processes, thought cycles. We may chance upon patterns where the person has an ill-defined sense of meaning around it, or let's say there may be turning points where they think that okay, I am not what this cognitive style is defining me as I thought to be before. What is there to me beneath all of this? So an identity change, a transformation of self identity. So these two cornerstones, when they are seeking for a deeper meaning making or for a change in their identity, when the conversation arrives to these themes, that's when talk about spirituality emerges, and it is always with respect to what the perspective that person brings in. So spirituality is a very broad term; it can never be generalized. It is always, I always say, 8 billion people, 8 billion different perspectives. So spirituality is what one makes out of it. So when the conversation arrives towards these themes, that's when it happens spontaneously. It occurs spontaneously.
And it's deeply personal. It
Yes,
can
sir.
be impactful and useful to some and may not be important at all to another person.
Yes, sir. Absolutely.
Excellent. So we're looking at two things. One is, of course, symptom relief, and the other is, of course, a deeper self understanding. And our hope, especially in terms of recovery, is that both these things are achieved. But more important than symptom relief, which I would say is an earlier goal, a deeper self understanding becomes a very, very important goal. What's the neuroscience that explains deeper self understanding?
So when we look the patients, and usually they come even with people with dementia, that my brain is doing something different. Instead of that, something is wrong with me. Nobody says there is something wrong or happening with me. It is something is my brain is doing it. And this self-regulated appraisal of the self comes from the anterior cingulate and the prefrontal circuits. While these circuits are not getting involved, it can be result from the trauma, infection, metabolic, whatever the insult the brain is leading, and these circuits will get into the tune that it is not me, it is something other than me which is happening to me. And when we trying to regulate this, so exactly these circuits turn that shame into the curiosity. That once I understand, so if I take an example, that I am unable to walk. I think my body is not giving me. Previously I used to do a yoga for at least for 1 hour. Now I'm feeling fatigue. When I get up immediately, I feel giddy or blackout like symptom. There is something is wrong with my body, and once that curiosity, like that shame, like something is wrong, turn into curiosity, and that's where we look at the symptoms like dysautonomia. And it's not just a psychiatric, it is there for any neuropsychiatric disorder. And then I wanted to understand why I am having these symptoms, and it's all of the symptoms of the anterior cingulate gyrus and the prefrontal circuits. Stimulating those again, if we look how we are helping them, and it is just not the neuromodulation alone. It can be the holistic care approaches like the pranayama, the breathing techniques, which also provides the oxygenated, more oxygenated blood to the brain. And I think that's where happening in the brain.
And of course, when you work with people, what is the point where you feel that recovery has happened and people are starting to, they stop asking the question, what's wrong with me?
So when the person develops a deeper sense of acceptance, so acceptance comes after understanding. When the intellectual insight has reached its culmination, and when they are beginning to realize, when the emotional insight begins to develop, so that's when they become more okay with who they are. So when we work on not pathologizing their experience, but rather find a meaning to it and learn and help them to reorganize their emotions, and help them to choose what to give more impetus to. So that's when they stop saying that, oh, stop asking what's wrong with me, and rather start working on the resources that they bring to the table. So that is the point, so where you have more acceptance means you naturally tend to not pathologize yourself. You tend to be more comfortable with who you are, and that's when you stop asking. That's when you become more confident in your own self, and you stop asking about what's wrong with me.
One of the things we talk about in therapy is co-regulation. Explain that. What is co-regulation? How does that happen?
So co-regulation is based on, I mean, it's a concept. It's based on the polyvagal theory, a theory that states that mammals have this autonomic nervous system, and that interacts with the neurophysiological substrates to and has a say in how the person responds to the environment, be it social or cultural or whatever it is. Right? So the co-regulation is a connect that one develops with their client, where we are able to modulate their sense of relaxation with our own sense of relaxation. So it begins with emotional validation. So when the patient feels emotionally validated, their threat response lowers, and when it lowers, they are able to pick on your body language, your facial expression, the tone of your voice, your heart rate, and everything. So the process is called neuroception, where the threat perception stops, and we are able to pick on what the other person is giving us and share a sense of connect. So when there is co-regulation, so co-regulation is, I will say, it is followed by intellectual insight. So that's when the person starts seeing the therapist as a safe base, as a secure base, who they can connect with, who they can rely upon, and who they can reflect on as an empty screen to work out with their emotions. So co-regulation is an important tool. It helps. One is that it helps to work on the emotional dysregulation part in tandem with the pharmacotherapy and neuromodulation. The other is that it helps the person to develop a sense of personal connect, a therapeutic connect with the therapist, which again helps to make the process much more deeper. It builds trust, safety, and efficiency for the therapeutic process.
Excellent. How do you see this as a neuroscientist?
And I think Dr. Mughal have explained it quite detailed. But if we look the vagal tone, the prosody, the facial mirroring, it is much below than our journal awareness cycle. It is just what we see is what we are attuned to do. So if a therapist who is not calm himself and very haphazard, the person who he is trying to work with, we can't say you can be calm and relaxed. So it is just the mirror. It is just like a mirror neuron theory, which is also in other, if we look the theory of mind in the people with autism. So if how we can able to attune, and I think that being that calm, providing them the right environment is what regulates this underlying mechanism of regulating our autonomic nervous system rather than just pushing it on. So I think it is goes like what we are teaching first, we should be master of that rather than we both are learning side by side. So I think that's what we will be. I will look put it.
Recovery for someone is obviously regaining autonomy, because one of the challenges with mental health being affected, either due to neurological disease or due to primary mental health conditions, is the loss of autonomy for many people. It could be partial, it could be very significant, depending on the kind of problem you are having. And for this, of course, neuroplasticity is very, very important. Can you explain what neuroplasticity is and how are we using that when we use technologies like neuromodulation that you're using so widely?
So, when we are looking for neuroplasticity or the change in the neuroplasticity via neuromodulation, it is like breaking the uh, patterns which are not working, as we discussed the adaptive behaviors or emotional dysregulation. That brain have got attuned to a new normal, which is not apt. Using the neuromodulation, we are breaking that repetition, getting into a self-sustaining mode, so that the brain don't need any extra scaffolding effect that I have to be protected. I have learnt new methods, I will keep on doing, and that is why the any form of non-invasive brain stimulation methods are so repetitive. Most of the times when we see the patient say, yeah, I'm feeling good, I see the change by the 10th session. So why we are doing the 30? And the reason is, we do 10 sessions, the chances of getting back to the square one are more because brain have not learned the new mechanism. By the time we reach 20 or 30 sessions, which is of course approved by the FDA in most of the cases, like depression, they say up to 36 sessions, it is tuning the brain to a point that it does not need the therapy anymore. So we don't want the patient who forever need us. We want the change to happen in the brain. They are self-sustaining and propagating from there that this is the direction I want to go, and they are on their way. So I think the neuroplasticity is challenged by the resistance what comes not comes from the psychotherapy. So we require psychotherapy, the neuromodulation to make that changes in our brain, and I think so that's where the whole concept of neuroplasticity comes.
In your journey with patients, what does autonomy look like clinically? How do you see autonomy play out in the clinical setting?
Sir, autonomy, to define autonomy, I will say it is to have control over their own sense of agency. So, yes, I may have certain challenges with my thoughts and emotions. I have worked through them. I have worked through them. I have made considerable improvement. I have made considerable to significant improvement, and now I am able to plan my own life. I am not looking at my life through the lens of my illness, but rather the illness is one part and parcel of my life experience, and there is much more to life. So, like, to draw inspiration from a previous discussion, the brain has much more reserves than what it has allocated for the illness part alone. So there is much more to life than just the the illness that has occurred to me, the experience of challenge that has occurred to me. So now I am now I am able to make my own plans. So even if I have symptoms which may be residual, I am able to consider myself as a person beyond all of this, and somebody who is not defined by my illness or my challenges. And now and even in therapy, they may have, there may be moments of disagreement between the therapist and the client. So now there, I mean, as a therapist, we know, okay, this is coming from your perspective. I know it is not unhealthy. I know you don't fall in line with my thought process, but that's perfectly fine, right? So that's when we know that the person has worked, a sense of autonomy has developed for him, where he is able to be his own self, stand for his own self, and yeah. So
Excellent. So, thank you both. I think it's been a very fascinating conversation. We started with emotional dysregulation, which is a feature that runs across a range of disorders, as we've discussed. We, I think, talked about how a holistic approach is required, where we need to go beyond medication, need to go beyond psychotherapy. We need to consider technologies like neuromodulation as enhancers of recovery, and how the combination is tremendously successful in putting people back on the journey to recovery. I think we've talked about how managing symptoms is only one part of what we have to do. The therapy window being identified, the development of insight, the development of a greater self awareness, self understanding, self agency, the restoration of autonomy, all of this leads to not just coming out of the illness that put me down, the condition that put me down. It also means that this is what helps me then go on a journey to finding my potential. And I think finding human potential is so important. And it's so important that everyone who has a mental health condition feels that it's possible to find my potential, not just recover, but find my potential. And I think you both talked about how, both from a science perspective, a technology perspective, and a clinical perspective and a therapy perspective, how working together makes a huge impact. And I'm sure I found this really interesting, and I really hope that everyone who listens to this goes away learning a few lessons. Thank you
Yeah.
so much for your time.
Thank you, sir.
Thank you, sir.